Now we'd like to invite Dr. Rajesh Fogla. He's going to talk about, I think, very important areas like glue applications, deep anti-lamellar keratoplasties in cases with infection or infectious keratitis. And he's one of the leading cornea faculty of our society, and is a torchbearer of India and across the world, especially in the field of cornea. And we all admire his, the potential he's shown us in the international field. And we'd like to see his presentation. Dr. Rajesh, please.
Thank you, Dr. Tityal. Good morning, everybody. I'll be talking about the role of glue and DALK in microbial keratitis. Cyanoacrylate glue is commonly used in medical surgical specialties where they use it to close wounds without sutures or augmenting the suture. It's basically a liquid monomer which polymerizes on contact with liquids. If you have a corneal ulcer, you can get a thinning or perforation either during the active stage of the ulcer when you have a lot of lytic activity, and sometimes it can happen even during the healing phase when the ulcer is beginning to regress, but because the cornea has become thin, it can give away and you can have this kind of sedal positive. In such a case, cyanoacrylate glue is useful to seal wounds which are at least 1 to 2 millimeter in size. Now, the way you apply is basically you take a plastic drape, you can punch out a 2 millimeter or 3 millimeter disc. You can cut out a cotton bud and use one end, you apply some ointment, then attach the small disc, the plastic disc to it, and then put a drop of cyanoacrylate glue on top of it. To dry the surface at the area of perforation, you put an air bubble in the anterior chamber, and then you debride the epithelium around the site of perforation, because if you don't debride the loose epithelium, the cyanoacrylate glue is not going to stay. And you can do that gently after you have placed an air bubble into the anterior chamber. So you can see that we are now trying to dry the wound. And the surrounding loose epithelium, you can use a dry Merocel sponge, you can use a fine tying forceps, and you can gently hold the epithelium and peel it off. There you can see that the loose epithelium is being removed. And once you have done that, then this small disc which is attached to the cotton swab with the ointment, you just bring it and you can place that over the site of perforation. This method of application ensures that the surface remains very smooth, unlike a direct application with a 26 gauge or a 27 gauge needle attached to a tuberculin syringe. You can apply the fibrin glue, but often you apply excess amount of fibrin glue, and the cyanoacrylate glue, and the surface becomes very irregular. So here you can see that that's a small disc that's there, and that either can be left behind or you can just peel it off. That comes off because the adhesive does not stick to it. And then you can put a large diameter bandage contact lens to cover that defect. That's how it looks post-operatively. Immediately day 1, day 2 post-op, you can see there's an air bubble in the anterior chamber. The eye is quiet. And at a month, you can see that the glue has dislodged, but the area of perforation has healed, and there is some amount of scarring, which is in the paracentral cornea. When you have advanced infection, no response to medical therapy, or if you have large perforation, the tectonic integrity is compromised, you need to do a penetrating keratoplasty, a therapeutic keratoplasty, which Professor Tityal is going to talk next. But I'm going to see whether there is a role of performing a lamellar keratoplasty in infective keratitis. The disadvantage of doing a lamellar keratoplasty is that you are potentially creating an interface and into which you can have recurrence of infection. The advantage is that you retain the host endothelium, you have a closed chamber, so basically the complications associated with the open globe can be minimized. So this is a paper back from 2002 where they looked at the role of lamellar keratoplasty in treating fungal keratitis, but they instituted the surgical intervention very early, within 7 days of the occurrence of infection, and they had favorable outcome in majority of their cases, in almost 93%, and 4 cases only had recurrences. But we know that fungi can penetrate deep into the cornea and sometimes even cross across the intact decimus membrane. But there have been other papers looking at the treatment of fungal keratitis using lamellar keratoplasty. This paper published in 2017 from Italy, where again they used it for smaller ulcers which are confined to the central cornea, the depth not exceeding 300 microns, and they used the big bubble technique. and they were able to successfully clear the infection using the DALK procedure. Another paper from China where they again used the big bubble DALK surgery. The recurrence rate was only about 9% in their series. So basically, yes, in fungal keratitis, at least my experience, I have not done lamellar keratoplasty for fungal keratitis because the time frame at which the patient presents to us is usually much later. The corneal involvement is much deeper, and if you do that, the chance of recurrence will be much higher. And our experience of treating fungal keratitis, we see a much higher volume of fungal keratitis than what they see in the West, and we have been able to medically manage them quite well. So I think we tend to persist with medical therapy for a longer duration of time. So this is one of the photographs from the publication showing the central fungal keratitis, which was managed successfully using lamellar keratoplasty. This is a nice paper from Donald Tan's group from SNEC Singapore, where they compared therapeutic DALK versus therapeutic PK, and they found that the success rate of eliminating the infection both with DALK and therapeutic PK is almost similar, but the risk of having severe complications like endophthalmitis was more when you do a full thickness therapeutic keratoplasty versus a DALK. The best corrected visual acuity of 6/9 or better was achieved more in the DALK group, and the long-term graft survivors were also better in the eyes which had the therapeutic DALK. That's some of their cases where they successfully performed the DALK procedure. The other indication would be acanthamoeba keratitis, and we all know that acanthamoeba keratitis is extremely difficult to treat medically. Patients often do not respond to the medical therapy, and if you keep continuing with the treatment, if the infection reaches up to the limbus or the sclera, then the battle is already lost, and sometimes despite the best of surgical intervention, you may not be able to successfully visually rehabilitate the patient later on. So even in this case, within 30 to 60 days from onset of symptoms, where the depth of involvement was less than 300 microns, they performed DALK, and they found that they had successful outcome, and they did not have any recurrence of infection in their series. This is another paper from L.V. Prasad, where they retrospectively reviewed the DALK performed in cases of acanthamoeba keratitis. This is published in IGO in 2020. So they divided them in two groups, advanced acanthamoeba keratitis versus early acanthamoeba keratitis, depending on the size of the infiltrate, whether it was more than 8 millimeter or less than 8 millimeter. But they found that the outcome was the 1-year graft survival and the eradication of infection was much better when the infection was less than 8 millimeters. So the basic thing is that you want to do a therapeutic DALK, you have to take the decision relatively early before the infection has spread to the peripheral limbus. So this is a case of DALK, acanthamoeba keratitis, where we had taken up the patient for a therapeutic DALK, and here we tried creating a big bubble technique. So initial debulking was performed. When we injected there, because of the infiltrate and the haziness of the cornea, initially we were not able to appreciate the formation of the big bubble, what we typically see in our cases, but then we saw that there was a type 2 bubble which was achieved, and we opened it up and successfully completed the surgery. You can see that we are removing the anterior stromal tissue to achieve good clearance of the infected stromal tissue. That's what it looked post-operatively. That's another case of acanthamoeba keratitis. Similarly, in microsporidial keratitis, where you don't have effective medical therapy, instead of resorting to a full thickness graft, if the infection is limited to the anterior half of the cornea, you can think about doing a lamellar keratoplasty, which was done in this case, and you can see post-operatively that the patient had a clear graft. But you have to watch out for recurrence, because in microsporidial keratitis, recurrence is quite common. This is another patient post-SMILE who had infective keratitis. So here also, instead of doing a therapeutic penetrating keratoplasty, big bubble DALK was performed, and this patient also did well following the surgery. This is a patient where you had a perforation which was sealed with glue and amniotic membrane. That's how the patient presented, with a large 2 to 3 millimeter perforation. We went ahead, did a DALK, and that's how the post-operative outcome was. So DALK can be performed even in the presence of large perforation. So basically, it's a good option, essential to eradicate infection, to maintain the integrity of the globe in microbial keratitis. Timing is critical, and surgical planning depends on the extent of involvement. The advantage of DALK is that it avoids endothelial rejection. Thank you for your patient hearing.